Here we have a mystery diagnosis, a case of stomach pain. Our patient for today is Mr. Carlos Irving. For his chief complaint, he states that he has been experiencing a lot of pain in his stomach and constipation with blood on his stool. He also states that he has been feeling more tired and weak these past couple of days. Carlos Irving is a 46-year-old black male who goes to the hospital complaining about constant abdominal pain that he has been experiencing for about 2 weeks now. His bowel movements have changed drastically from being constipated, then diarrhea with blood present on his stool. He has also been experiencing fatigue as of recently. So what can we identify as of right now? His abdominal cramps have been consistent for 2 weeks now and is constipated. He also has diarrhea along with blood present on his stool. Another point to make note of is that his energy levels have decreased lately. Now on to looking at the objectives. For Mr. Irving's past medical history, he has only had hypertension for about 3 years now and is being treated with a thiazide-type diuretics. For his family history, his father and mother are still alive, 70 and 74 years old. His father has chronic obstructive pulmonary disorder and his mother has type 1 diabetes. Mr. Irving has no known siblings and his maternal grandfather had colon cancer. For his social history, Mr. Irving is a smoker. He has 3 cigarettes a day and finishes 1 pack in a week. He denies any drug use and drinks during special occasions only. He has a pretty unbalanced diet and doesn't consume the needed nutrients every day. He casually gets fast food since he stated in his own words it's fast. He is also very inconsistent with taking his vitamin supplements. What factors can we take away from this? We should keep in mind that Mr. Irving's family history can play a role in this as well. His father has chronic obstructive pulmonary disorder, his mother has type 1 diabetes, and his maternal grandfather had colon cancer. His social history is alarming as well. He is mildly a heavy smoker and has a very unbalanced diet. He also knows to take his supplements daily, but he isn't consistent with it at all. Now looking into the review of systems. As we can see here, Mr. Irving is positive for blood and stool, progressive restlessness and fatigue, abdominal pain, constipation and diarrhea, and lightheadedness. Mr. Irving is negative for cardiac and pulmonary disease and palpitations. The medications Mr. Irving is taking is chlorthalidone of 25 milligrams once a day orally, and he is also to take his multivitamins, vitamin B12, vitamin D, omega-3 fatty acids, and magnesium. Mr. Irving doesn't have any known allergies. Next we have here are the subjectives for Mr. Irving's physical exam. For the general exam, Mr. Irving appears tired. He is alert and oriented to person, place, and time times 3. For his vital signs, his blood pressure is 140/90, his respiratory rate is 20, his height is 5'11", his weight is 220 pounds, and in kilograms is 99.8. His resting pulse is 72.8, and his temperature is 98.5 degrees Fahrenheit. For his skin, it's warm and normal colored, and there's a slight turgor. It is also smooth and dry. What seems to be alarming from his physical exam? His blood pressure is pretty high since he does have hypertension, and the slight turgor and dryness of his skin indicates that he is dehydrated. For Mr. Irving's head, eyes, ears, nose, and throat examination, he presented a normal cephalic and an atraumatic head. His oral mucous membranes are pale but moist. He was negative for swollen lymph nodes, and his conjunctiva was slightly pale. For his lungs examination, no wheezing or crackles were present, and his breathing sounds were bilateral. For his cardiac examination, he was positive for tachycardia and negative for any murmurs and rubs. For his abdominal examination, it was mildly obese and tender. There weren't any masses present, so he was negative for splenomegaly and hepatomegaly, although he was positive for bowel sounds and pain on the left side of his abdomen. For his genitourinary and rectal, He presented normal external male genitalia, although he was positive for stool guaiac. For his musculoskeletal and extremities examination, he was negative for cyanosis, and no edema or ulcers were present. And lastly, for his neuroexamination, he was alert and oriented ×3 with good responsiveness, and his vibration senses were intact, and reflexes were also intact bilaterally. What do we know from these examinations? His conjunctiva are slightly pale, which could mean he is anemic. His abdominal examination is quite alarming as well. His abdomen is slightly obese and tender, and can physically see the pain on his face when he was getting examined for the left side of his abdomen. For his stool guaiac, he tested positive for it, meaning there's also blood present in his stool that isn't already visible to the naked eye. Mr. Irving decided on getting a colonoscopy done to detect anything out of the norm and to catch anything early as soon as possible. When the colonoscopy was done, the results showed that there is some sort of growth growing on the descending colon. The descending colon is part of the large intestines that passes down on the left side of the abdomen towards the rectum. Mr. Irving then took further action as a follow-up from his colonoscopy and had CT scans done as well to see where these growths could spread to. The CT scans were done for Mr. Irving, and it was definitely finalized that these growths were seen in his descending colon through the CT scans as well. More images were done to see if these growths have spread to other areas of the colon, and the findings did indicate that it is slowly spreading towards the sigmoid colon. The sigmoid colon is much more near the rectum and anus and what connects the descending colon to the rectum. The doctor did also recommend Mr. Irving to get a CBC test done, and he consented to it. The reasoning for this is to see any abnormalities with his red blood cell count and white blood cell count. So once the results of his laboratory test findings were finalized, it indicated very low red blood cell count, meaning Mr. Irving does have anemia. And as well as looking at the white blood cell count, the abnormality of it means that there is a high chance of a cancer being present. For Mr. Irving's diagnosis, the doctor ruled out any inflammatory bowel diseases, irritable bowel syndrome, diverticulitis, and colitis. The doctor diagnosed Mr. Irving with primary colorectal lymphoma. For the colonoscopy that was done, the camera examined the colon, anus, and rectum, and the results find that the lymphoma was growing on the descending colon and is slowly spreading towards the sigmoid colon. The CT scans showed detailed cross-sectional images of the enlarged lymphomas growing on Mr. Irving's colon. And the CBC lab test that was done resulted in a low red blood cell count, which is anemia, and an abnormal white blood cell count that indicated the occurring of a cancer. This takes us to the pathogenesis of primary colorectal lymphoma. It is known to be one of the most rare and uncommon colon or rectal cancer. It is a cancer of the lymphatic system that includes the lymph nodes found in the abdomen, pelvis, chest, neck, and underarms. It is also known to be a heterogeneous group of malignancies which arise from clonal proliferation of T cells, B cells, and natural killer cells. It involves the colon or rectum due to a widespread of systemic lymphoma. The symptoms are usually delayed and nonspecific. And finally, patients who are found with Kichel masses are a higher risk and are in need of urgent intervention. For the epidemiology of primary colorectal lymphoma, it usually affects the age group in the 5th to 7th decade of life in males. Males are more at risk than females, with female ratio being 1.5 to 1, and a 5-year survival rate with persons of the age 60 having a better median survival time. The two treatments for Mr. Irving is to surgically remove the lymphomas and a combined targeted therapy if his cancer and condition does worsen, which is very likely. Bevacizumab and monomethyl auristatin E, which is basically a beta-glucuronidase responsiveness albumin binding prodrug, which are two targeted therapies. This treatment promotes therapeutic activity such as the FOLFOX, a chemotherapy regimen, and bevacizumab, are both used to currently treat patients with colorectal cancer. The efficiency of both targeted therapy is due to either a synergistic or an addictive effect that are selectively released from glucuronide prodrug in the microenvironment of a tumor. For this summary, Mr. Carlos Irving is diagnosed with primary colorectal lymphoma. He is still in the early stage of the cancer and is very lucky to have made action with the early detection. He is currently due for a surgical removal of the lymphomas in 2 days. It is mandatory for him to have regular cancer screenings to be done monthly to detect any new growth after his surgery. If new growth does take place, new extensive treatments are to be done as soon as possible, such as chemotherapy and combined targeted therapy. The doctor gave him a life expectancy of 5 years since there is a high chance of his condition worsening. For future implications, new treatments are still getting tested and discovered, such as the Shield liquid biopsy. This test looks for the presence of any changes to the DNA called the cell-free DNA. It will indicate the presence of a tumor or a precancerous growths in the colon. The approval of this test was due to it detecting colorectal cancers in more than 83% of patients than the ones who did with colonoscopies. Surgery and chemotherapy are said to be two of the most optimal for patients' welfare. For Mr. Irving's health history, his diet, his smoking habit, and genetics did play a role in him having primary colorectal lymphoma. If we think back to his family history, his maternal grandfather did have colon cancer. Smoking does worsen the condition of his primary colorectal lymphoma, and his diet as well can worsen it too. One of the crucial actions that Mr. Irving is to take on after his surgery is to take preventative measures such as getting regular screenings monthly and taking care of his overall health, such as eating better, a smoking cessation, and getting more active, and as well as taking his supplements every single day. So who is more at risk? Males around the age of 40 to 60 years old are mostly at risk, but still can affect younger men. Signs and symptoms to look out for is change in bowel movement, blood and stool, diarrhea and constipation, the feeling of fatigue more often, sudden weight loss, and abdominal pain. Make sure to always get lab tests and imagings done, as CBC tests can indicate lymphoma cancer and anemia, which is very common in colon cancer patients. CT scans can catch tumors that might have spread to other areas. And regular cancer screening should be done to detect worsening of the cancer. And here are my references. Thank you.